Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome my dear students in my surgery lecture number 66, that is the cyst of the epididymis and hydrocele. In this lecture we will learn cyst of the epididymis, spermatocele, Epididymo-orchitis, hydrocele and types of hydrocele, vaginal hydroceles, congenital hydrocele, encysted hydrocele of the cord and its treatment. First we start with the cyst connected with the epididymis. Cyst which may occur in connection with epididymis can be divided into two broad groups. First, cyst of the epididymis, which are congenital and usually derived from an embryonic remnant around the epididymis and is filled with the crystal clear fluid, which are usually multilocular cysts. Etiology: these cysts are due to the cystic degeneration of remnants of the paramesonephric and Mullerian duct, the appendix of the testis, that is the sessile hydatid of Morgagni, remnant of the mesonephric duct and Wolffian duct system, the paradidymis or organ of the Giraldes. This is the most common cause. Appendix of the epididymis or pedunculated hydatid of Morgagni, the vasdeferens of Haller. These are the etiologies for the cyst of the epididymis. Now second cyst of the epididymis is the spermatocele, which has an awkward condition and a unilocular retention cyst derived from some portion of the sperm-conducting system of the epididymis. Dear students, here is the image you can see on your screen is the cyst of the epididymis. It is clearly seen the crystal clear fluid, and second is the ultrasonic image showing the epididymic cyst also, and this is the third image, animated color image is also showing the picture of the spermatocele. This is the acquired condition, retention cyst derived from the portion of the sperm conducting system of the epididymis. Now this is the fourth image clearly showing the normal testis and the spermatocele is clearly seen in this image. Now Epididymo-orchitis. This can be divided into acute epididymo-orchitis and chronic epididymo-orchitis. First we will see the acute epididymo-orchitis. In fact, the epididymis is the first inflammation which is known as the epididymitis, and later on infection spreads to the testes, and then the condition is called epididymo-orchitis. Means start with the epididymis and up to the testes. Now the etiology of this condition: at the first infection reaches the globus minus and the epididymis via vasdeferens, and the infection usually comes from either urethra, either prostate, or from the seminal vesicles. Such infections may be of two types. First is the sexually transmitted group from urethritis. This occurs in young patients and causative organism is mostly chlamydia and gonorrhea. And second etiology is the other type is associated with hydrostatic pressure associated with voiding or physical strain, which force infected urine from urinary tract infection or prostatitis or following prostatectomy or following prolonged catheterization through urethra or prostate via ejaculatory ducts and the vasdeferens to the epididymis. Dear students, here is a clear image on your screen. You are seeing that is the typical picture of the Epididymo-orchitis. Left side image is in pink color, which is the normal epididymis and testes, and another image is red and swollen, that is the Epididymo-orchitis. This is the more clear picture, normal picture of epididymis and testes, and second image is showing the epididymitis with orchitis. Now pathology of the acute Epididymo-orchitis. At first there is cellulitis of the lower pole of the epididymis. Infection spreads from the lower pole to the upper pole. The whole epididymis becomes swollen and indurated. Tunica vaginalis secretes serous fluid which becomes purulent. Gradually the testis become swollen due to the congestion and later on involved by infectious process. The tubular epithelium may show necrosis. Now the clinical features: the initial symptoms is pain and swelling of the epididymis along with fever, malaise with chills. The scrotal wall becomes red, edematous and glossy. Epididymis may become adherent to the scrotal wall. Occasionally the infection may go up to the abscess formation and discharge of pus may occur through the scrotal skin. Now the sign of this condition are: two conditions should be kept in mind when one comes across a case of acute epididymo-orchitis. That is, first it may develop from mumps, and another condition is the acute tuberculous epididymitis. Now the investigation is to be done in the Epididymo-orchitis, that is the hemogram shows marked elevation of white cells with shift to left side, and culture of urinary infection. Scan and ultrasound of the scrotum may help in this diagnosis. And the treatment is rest in bed with elevation of the scrotum with a scrotal suspensory bandage and cotton wool. Doxycycline 100 mg daily is particularly effective in young individuals with chlamydial infection. Otherwise, broad spectrum antibiotic with ampicillin, tetracycline and aminoglycosides may be tried. Now, second point, that is the chronic Epididymo-orchitis. The etiology is the tuberculosis is the main cause of the chronic Epididymo-orchitis, and the infection is retrograde from the tuberculous focus in the seminal vesicles. Clinical features, it mainly the cracking swelling of the epididymis which is firm and aches a little, means pains a little, and special investigation should be performed. That is the urine and semen should be examined for tubercle bacteria. Chest radiography and intravenous urogram may indicate tuberculosis of the lungs, renal tuberculosis respectively. And the treatment of this chronic Epididymo-orchitis are primary tubercular focus must be treated with anti-tubercular drugs. It must be remembered that anti-tubercular drugs are less effective in genital tuberculosis. Always remember these, students. So, if resolution does not occur after a full course of anti-tubercular chemotherapy, epididymectomy and even orchidectomy should be advised. Now the next point is the hydrocele. A hydrocele is an abnormal collection of serous fluid in the tunica vaginalis of the testes or within some part of the processus vaginalis. According to the etiology, hydrocele can be divided into two categories. First is the primary or idiopathic hydrocele, the cause of which is unknown, that is, there is no associated disease in the testes or the epididymis. Second is the secondary hydrocele, when hydrocele is secondary to a disease in the testes and or in the epididymis. A secondary hydrocele is usually small and lax. Dear students, here is a clear picture showing the normal scrotum and the hydrocele. The serous fluid collected in the tunica vaginalis on the left side of the scrotum is clearly seen. This is the transverse image, lateral image showing the normal side. There is the epididymis, scrotum and the testicles is seen, and where in the right side of the image showing the hydrocele, the serous fluid collected in the tunica vaginalis is clearly seen. This is the another image. There is a huge scrotal hydrocele which is upper end is in the abdomen, up to the abdomen is clearly seen. The first is the primary or idiopathic hydrocele. 5 varieties of such hydrocele can be seen. First is the vaginal hydrocele, the commonest type of the primary hydrocele. Encysted hydrocele of the cord, infantile hydrocele, congenital hydrocele and funicular hydrocele. Last 3 are unusual. 3 very rare varieties are hydrocele of the canal of Nuck, hydrocele of the hernial sac and hydrocele in Bizac. Now, first is the vaginal hydrocele. This is by far the commonest variety of the hydrocele. In this condition, there is an abnormal accumulation of serous fluid within the tunica vaginalis. Now, the etiology, though there is no associated disease of the testes or the epididymis, yet there must be some reason why abnormal accumulation of the serous fluid takes place in some individuals and or in all. The possible reasons are defective absorption of hydrocele fluid by the tunica vaginalis. This is said to be the most common cause, though the reason is still obscure. Damage to the endothelial wall of the low-grade infection is the most probable examination. Second etiology is the excessive production of fluid within tunica vaginalis, and next is the interference with drainage of fluid by the lymphatic vessels of the cord, and the fourth is there may be some connections with the peritoneal cavity as in the congenital variety. Dear students, here is a clear-cut image showing all types of the hydrocele. First image A is showing the congenital hernia which is connected with the peritoneum and the fluid is collected in the tunica vaginalis. Second is the funicular hydrocele. The hydrocele fundus sac is up to the epididymis is clearly seen, and third is the infantile. There is a obstruction, occurrence of the sac. That's why there is a collection in the tunica vaginalis. Fourth is the encysted hydrocele hernia, that the lower and upper both pole of the cyst are closed and the fluid is collected in the lumen. That's why it is the encysted hydrocele of the cord, and this hydrocele or this fluid filled water bag in the parallel with the cord. That's why that is the called as the encysted hydrocele of the cord. And fourth is the vaginal hydrocele, that is the commonest type of the hydrocele. Now, the composition of the hydrocele fluid is, the hydrocele fluid is a amber color. Its specific gravity varies between 1.022 to 1.024. It contains water, inorganic salts, 6% of the albumin and some fibrinogens, and in old standing cases variable amounts of the cholesterol and tyrosine crystals. Due to the presence of the fibrogen, the hydrocele fluid, when comes in contact with the blood, clots firmly. When it does not come in contact with blood, the hydrocele fluid does not clot. Now the clinical features of the vaginal hydrocele are: first, the history, the age. Primary hydrocele is common in middle-aged people. It is uncommon in children. Geographically distribution, hydrocele is more common in tropical countries. Symptoms, in majority of cases of only complaint is the swelling of the scrotum. Occasionally, patient does not seek advice till the sac has attained enormous size. Now the local examinations. First is the position. Though hydrocele is often unilateral, it may be bilateral as well as. And the second is on inspection, one side or both sides of the scrotum are enlarged with notch at middle of the affected side of the scrotum. This is quite characteristic. And third is the fluctuation test is positive as it is a cystic swelling. The cyst is often tense in primary hydrocele, and the next is it is purely scrotal swelling and one can get above the swelling, that is the inguinal hernia. Transillumination test is always positive as the hydrocele fluid is clear, except probably some cases of secondary hydrocele when it is secondary to Epididymo-orchitis and the fluid becomes turbid, or in some cases of filarial hydrocele when the skin and the tunica are thick. On percussion, it is always dull, like the inguinal hernia. And the reducibility, vaginal hydrocele cannot be reduced. Next is the palpation of the testes. Though occasionally testes may be palpable, the posterior of the vaginal hydrocele, but as the rule of the testes cannot be felt separately as the fluid or hydrocele surrounds the body of the testes. Now the differential diagnosis of vaginal hydrocele should be made with the inguinal hernia, hematocele, pyocele, chylocele, filariasis of the scrotum, cyst in relation to the epididymis, insisted hydrocele of the cord, tumors of the testes. Now the complications of the vaginal hydroceles are infection, atrophy of testes, rupture may be traumatic or occasionally spontaneous, hematocele may result from trauma but occasionally may occur spontaneously. Hernia of the hydrocele sac occurs in only long-standing cases. The sac herniates through the dartus muscle due to the tension of the fluid. And next complication of the vaginal hydrocele is the calcification of the sac, sometimes occur in long-standing cases. Now the treatment is the operation is definitely the treatment of choice. There are types of operation: Jabulis method of eversion of sac, Lord's procedure of excision of sac and excision of the sac, and subtotal excision. These are the 4 types of the operation has to be done in the vaginal hydrocele. That is the commonest type. And the next method is the tapping. This operation does not a radical treatment but is oftenly indicated in case of the old patient when the patient is inoperated or not fit medically for the operation. Now the next point is the congenital hydrocele. In this condition, the process of vaginalis remains patent, so there is a direct communication of the tunica annularis with the peritoneal cavity. The communicating orifice at the deep inguinal ring is too small for the development of the hernia. Now the next point is the insisted hydrocele of the cord. When the central portion of the process vaginalis remains patent but its upper and lower parts are obliterated, such condition is developed. Fluid accumulates in the patent portion of the process vaginalis and presents a swelling in relation to the spermatic cord, hence it is called insisted hydrocele of the cord. Such swelling is localized oval cystic swelling situated in the scrotal region, inguinoscrotal region, or in the inguinal region. Dear students, here is a good picture showing the normal testes, normal scrotum, and the picture is showing the non-communicating hydrocele, that is there is a complete cyst, complete sac of the tunica vaginalis, the fluid is collected, and the third one is showing the communicating hydrocele with the peritoneal cavity. That's why the size of that cyst of the hydrocele is sometimes more or sometimes less. Now this is the clear ultrasonic picture of the insisted cord hydrocele. This picture is showing the differentiation between the congenital hydrocele, the funicular hydrocele, infantile hydrocele, and the insisted hydrocele of the cyst. 4 types of hydrocele is seen in the same picture. This is the operation of the insisted hydrocele of the cord. Dear students, there are very good videos of operation of Jabulis method of eversion of sac, Lord's procedure of excision of sac, and subtotal excision or tapping. You can watch it on the YouTube. Here is the end of our surgery lecture number 66, that is the cyst of the epididymis and the hydrocele. Thank you.